Our next speaker, again, another fortunate gentleman to have with us. His name's Dr. Raj Vuppalanchi. His patients know him as Dr. V. He's an IU hepatologist, has a diverse and deep background in clinical investigation within autoimmune liver diseases, including AIH, but also PBC and PSC. He's also a world-renowned expert on using Fibroscan, has brought Fibroscan to our institution to allow us to look at a non-invasive way of measuring liver stiffness. So I will let Dr. V talk about his treatment approaches and goals in autoimmune hepatitis, a really, really important topic. Thanks, Dr. Vuppalanchi.
Thank you. Morning. Before I get into my talk, I want to share with you a recent experience of mine with my patient. Young guy, known him for 8 years. I inherited him from my senior colleague who retired. I walked him through tough times, good times, complications, recovery, beating cancer, making sure that his appointments don't mess up with his basketball refereeing over time. And I told him about this conference, and he said, "Doc, thank you so much. I have never met anybody else with autoimmune hepatitis in this 15 years of my diagnosis." So I do feel that this is a very powerful moment for myself, my patients, and I would like you to capitalize this opportunity and run with this momentum to do more with whatever Craig and AIHA has started. So after that, I know there are a lot of questions with regard to therapies and treatments for autoimmune hepatitis. There is confusion, there is controversy between how people treat in US versus Europe, and how people stick to guidelines versus using off-label based on experience. So you will hear a lot of stuff that may be different from what you have gone through, but this is what we do here at IU. I want to first go overview with standard of care treatment options, then how do you monitor treatment response. I want to briefly walk you through some difficult, unusual situations where we have to explore some unconventional treatment options when standard of care treatment therapies don't work or not tolerated. Some drugs themselves cause autoimmune hepatitis, and that causes more confusion in the real world. Pregnancy and autoimmune hepatitis, I know there's a separate talk. I'll not spend a lot of time with that. And then the question that often comes to us, am I committed to lifelong therapy or can you stop? What are the goals of treatment? Of course, when there is acute inflammation, you want to control the inflammation, and it's called inducing remission, which is essentially normalization of liver tests. Of course, we want to prevent the disease progression. We don't want the disease to flare up, and improve survival. However, not many people talk about how about reversing the damage that is already there. What are you doing for that? Does the remission guarantee me reversal of the scar that is already present? How am I dealing with long-term consequences on being these medications? What risk am I paying 10 years from now, 15 years from now for being on this medicine forever? So some of those questions that do come up that are not very important because all of us are still fixated on, hey, why do you complain? I have a medicine, your liver enzymes are normal, everything else is a price to pay. But I think we can do better and ask additional questions. And I'm hoping that this is just the beginning of addressing those questions. What would be an ideal treatment option? Of course, when patient is newly diagnosed, liver enzymes are very high. It doesn't matter whether it is IV or oral. It has to act fast. It is safe and easily tolerated, preferably no side effects. But at that time, in that situation, I'm willing to take some side effects as long as my patient gets better very fast. However, things may change a little bit with regard to maintenance because this is a long-term course, and I'm not going to accept an IV drug for a long-term maintenance regimen, so I need it oral, no long-term side effects, safe, easily tolerated, and to be frank, it needs to be affordable. A lot of times the cost is not put into the equation, but it can eventually get you after 1-2 years. And if your insurance has high copay, it can be difficult. And making it even more challenging is many of the medications are off-label. And if when we ask for a patient assistance program to the company says, well, you know, this drug is approved for post-transplant, and you're using it for autoimmune hepatitis, and we cannot help you in an off-label indication. So where do we go with that situation? So what are the guidelines? You will see that there are absolute guidelines, relative guidelines, and some, absolute indications for treatment, relative indications for treatment, and maybe monitoring in this right side last column where they say maybe you don't have to treat autoimmune hepatitis. In my mind, every patient with autoimmune hepatitis has to be treated at least with a maintenance regimen because there is a chance for spontaneous flare-up, and we cannot afford to have that flare-up because there may not be enough reserve left in the liver to handle additional insult. So in my mind, I really don't believe absolute, relative, and none. As long as the liver enzymes are normal and whatever it takes to keep the liver enzymes normal is an indication for me in my mind to keep a patient on treatment. So here itself, I'm showing you data that is published in our guidelines with regard to where you need to treat and where you don't have to treat, but in real world, it's different. So what is the historical aspect of treatment for autoimmune hepatitis? The treatment goes way back in 1950s, where they have recognized that there is some sort of an autoimmune liver problem, and if you increase the steroid production in the body, the inflammation decreases. So what they used was a hormone called cosintropin, which stimulates the, which mimics the hormone made by the pituitary gland that stimulates the adrenal gland to produce cortisol. And this was first used in a young lady with autoimmune hepatitis, and they found that it improved the liver enzymes. Later on, the steroids came into the market, and they did not really need this intravenous drug to stimulate the body's own production of steroids, and it phased out, and it's no longer used. This is the standard of care that we have, and here you have the table which shows what is done in US, what is done in Europe, and people can use prednisone monotherapy or prednisone along with azathioprine as a combination regimen. You have a substitution with the budesonide in patients who either cannot tolerate prednisone or in patients whose insurance will allow us to use budesonide. In Europe, they give Imuran based on the weight. In US, the standard of care is to give 50 milligrams, which I don't think is the right approach. Why do we need to use Imuran and prednisone? Because we need something that is fast acting, and prednisone works fast. Imuran takes 6 weeks to kick in, so we really don't have the opportunity to use Imuran in acute setting. So we have to start off with prednisone to get immediate control, and in my personal practice, I start off with Imuran as long as there is no jaundice right away, so that allows me to taper off the prednisone as fast as possible. So I'm very aggressive with tapering prednisone, and understandably so related to side effect profile. So at IU, we go by weight-based dosing for azathioprine, and I preferentially prefer prescribing budesonide, especially when there is no cirrhosis, and that allows me to maneuver the whole situation with a minimal side effect profile. So this is the typical approach. Start prednisone. If there is good response, add Imuran, and then taper the steroids. This is on the extreme left. That is the ideal situation. But then if prednisone doesn't work, we have to question, did we get our diagnosis right? And if not, look for other diagnosis. And if we did get the diagnosis right, maybe the oral prednisone is not enough. Maybe patient has to be hospitalized and given steroids IV. And if Imuran, prednisone still don't work, then we have to go for additional treatment options. Now, I know Dr. Gavre talked about Budesonide, Prednisone, which one, and a study has been done in Europe. Again, most of the treatment trials and knowledge comes from Europe because US is lagging behind with regard to research for autoimmune hepatitis. There's a lot of graphs, but just look at graph A. You have a Budesonide arm, Prednisone arm, and both the arms got Imuran. So look at complete response at 6 months. Budesonide was much better than Prednisone. And if you look at the 12-month response, they both are equal. So the conclusion is Budesonide gets you into biochemical remission much faster. And long-term, it's no different from Prednisone. So why do we even have to use Prednisone? Look at the steroid-related side effects, Budesonide arm versus Prednisone. Much, much less side effect profile with Budesonide. Acne, buffalo hump, diabetes, moon face, everything is much lower in the Budesonide arm. So in this day and age, it really doesn't make sense to use Prednisone at all. The only reason I use it is because of insurance issues. Typical dose is 9 milligrams per day, used in conjunction with Imuran, minimal to no systemic side effects. It cannot be used in patients with cirrhosis, but look at the cost. 3 milligram pill, this is MSRP granted. You know, it's different with different insurance, but it's $523, whereas Prednisone you get for $4 in Walmart. So that's that. A little bit about personalized medicine. Not everybody handles the Imuran the same way. There's a genetic testing. This is how the Imuran is broken down in the body. There's an enzyme called TPMT. If you do not have the enzyme levels enough, most of the drug is shunted towards the other side, and it accumulates in the bone marrow, causing severe bone marrow suppression. It's around 0.3% of the population that doesn't have the enzyme. So in the past, we used to start at 50 milligrams and get CBC every 2 weeks, look at the white count and hemoglobin, and then if it is all normal, we used to increase the Imuran, and it used to take 6 weeks, 8 weeks to get to the right dose of Imuran. But right now, we can get this blood test at the time of initial diagnosis. If the enzyme is normal, we start at the high dose. So that way, we can get the patient off the Prednisone much faster than the traditional, let's see how we can increase your Imuran over the next 3 months, and then the patient has to be on Prednisone for all these months. This way, we minimize the side effects related to steroids. How do we assess response to therapy? We look at the liver enzymes. It's cheap. It's very easy. We can look at the serum immune globulin levels, because this is representing the immune dysregulation that is happening in the body. Of course, we can do a liver biopsy to see actual inflammation, but really to assess response from liver biopsy is not standard of care, because you can get that sense from blood tests, and it's not easy to continue to promote liver biopsy to monitor response. It's an invasive test and all. It doesn't make any sense. Now, at the time of initial liver biopsy, we are looking at 2 things. One is the degree of inflammation and helping with the diagnosis, but also how much scarring is already there, because a lot of times patients may be having autoimmune hepatitis for several years before it comes to diagnosis and recognition, and there may be already scarring. And how do we assess response to treatment? Is the scarring reversing? So that's where this non-invasive assessment of fibrosis comes. Of course, we can't repeat a liver biopsy to assess resolution of fibrosis. It's invasive. So it's very important and unmet need to understand how we can look at the fibrosis without actually doing a liver biopsy. And it is in this place that we are trying to make a contribution to science, whether we can use Fibroscan to assess response to treatment. It's a simple instrument. What it does is it uses some ultrasound and it uses some vibration. And it sends the vibration through the liver and measures the speed of the vibration that goes through this liver using an ultrasound. And the speed at which the vibration moves through the liver gives you a sense as to how stiff the liver is. For example, regular liver should be like a jello. But when there is a lot of scarring, it becomes very hard, and the vibration goes very fast if the density of the tissue is very high. So these are the pictures that we get. In a healthy liver, the stiffness is very low. Normal liver stiffness is around under 7 kilopascals. The velocity is low, and it translates with this equation to stiffness, and the stiffness is low. But if the velocity is high, because the tissue is very hard, then it translates to high stiffness. So we can assess response to treatment. We can assess whether the resolution of fibrosis is happening based on using the Fibroscan without actually repeating a liver biopsy. And in our practice at IU, we use this on a yearly basis to tell patients, well, your liver enzymes have been normal, seems like your stiffness is improving over time, and I do believe that your scarring in the liver is reversing. We won't be caught off guard 5 years or 10 years from now with a diagnosis of cirrhosis, because we are documenting more, in addition to liver enzymes, your stiffness is improving over time. So this is how we do. It's an FDA-approved device for assessment of fibrosis in chronic liver disease. It has not been specifically tested for autoimmune hepatitis, so it's not well studied, and we are trying to assess the current questions for autoimmune hepatitis using this Fibroscan. We want to find out if this is a predictor of response, is this a predictor for resolution of fibrosis, and can we use this to answer the question with regard to can we stop treatment at any particular time point. There are some nuances with regard to using Fibroscan. One of the main things that increases the stiffness is inflammation in the liver. So if it's a new diagnosis of autoimmune hepatitis and there's a lot of inflammation, you will get a very high value of stiffness. So we don't know how to handle the number in acute diagnosis versus chronic diagnosis of autoimmune hepatitis. What are the signs of treatment failure? Of course, worsening symptoms know that our treatment is not working, increase in the liver enzymes and bilirubin, progression in the liver inflammation, of course, signs of liver failure, jaundice, ascites, encephalopathy, bleeding from the esophageal varices, and we are continuing to increase the dose of the drug with no improvement in the liver enzymes. So that's when we have to get into unconventional therapies. These are drugs that we borrow from post-liver transplant situation, and with the thinking that these drugs should work for autoimmune hepatitis also. I have some patients on Cellcept, Prograf, some on Rapamune, and this is a new drug called everolimus. Pricing is not still available, but all of them are pills. But look at the bottom with regard to the cost of these drugs. $400, $900, $900 for the lowest dose possible. So it just becomes very difficult to convince the insurance about using these drugs for autoimmune hepatitis patient when the traditional therapies don't work. And recently I spent 2 hours doing the prior authorization from one phone call to another phone call to another phone call. Finally, I think the call was forwarded to India, and because I could recognize the accent. And she asked me so many questions, and I was having difficulty understanding her accent. So I did all the questions and all that, and 3 days later I get the fax denied because it's off-label. I mean, why did you even waste my time if you were to deny it? So rarely we do have to go into liver transplantation. This is mostly in acute liver failure. As you see, these are the various causes of liver transplantation, and you see the autoimmune hepatitis show up, so it does happen. I know Dr. Gabriel is going to speak more in detail with regard to the role of liver transplantation in autoimmune hepatitis. Luckily, it's not as common, and with better therapies, it is becoming less and less of an issue with regard to pursuing transplant for autoimmune hepatitis. Now, I did talk about drug-induced autoimmune hepatitis. This is something that we do see here. We have expertise. We have several NIH-funded clinical trials looking into drug-induced autoimmune hepatitis. One unfortunate situation that we do see is little old ladies put on nitrofurantoin, which is macrodantin, for recurrent urinary tract infection, several years on it for prophylaxis, end up with drug-induced autoimmune hepatitis progressing to cirrhosis. So that's one thing we see. Some of the acne drugs that teenagers use on long term, they can cause drug-induced autoimmune hepatitis. And interestingly, we are also observing some herbal and dietary supplements that cause autoimmune hepatitis, like picture. So not everything in nature is safe. You have to remember volcanoes and recently earthquake in Nepal. So one has to be cautious with regard to supplements, thinking that they can have also some problems. So how do we deal with drug-induced autoimmune hepatitis? Of course, we stop the drug, and most of the times patients get better, but sometimes the trigger already has happened, so there is a perpetuation of injury, and we have to treat with the same way as if it's a regular autoimmune hepatitis. We have to give prednisone, budesonide, Imuran, but what we do is to look early, 6 months to 1 year, we start thinking, if this is drug-induced hepatitis, autoimmune hepatitis, do we really have to commit this patient for lifelong therapy? Because we have a trigger event, and the trigger event is taken off, so we aggressively look to see if we can stop the immune suppression. And in general, natural history of drug-induced autoimmune hepatitis is much better than the regular autoimmune hepatitis, and this is a Kaplan-Meier's curve. The green line is the drug-induced autoimmune hepatitis, and the blue is the regular. Green line is much better than the blue. So that brings to the most controversial question that we deal with, permanent drug withdrawal. It's very desirable, but is it achievable? In studies that have done this, the frequency of treatment-free state varies from 19% to 40% in patients who were followed for 3 years or more after drug withdrawal. And the general proposal for criteria for withdrawal is that you need to have normal liver enzymes for at least 3 years, normal serum IgG levels, and a repeat liver biopsy showing no inflammation. That if you satisfy all these criteria, you have a 40% max chance of being off drug. So it's still not anywhere near the desirable state. I have done some, but I lose enthusiasm over time with regard to stopping the drug. So I go for the lowest dose possible to maintain them. And my typical dose is Imuran at 50 milligrams, leave them on that. It's a low dose, doesn't have many side effects and stuff like that. I have a slide on pregnancy, but Dr. Sozio, my partner, is going to be talking about pregnancy and autoimmune hepatitis later on. So what are the unmet needs? It's a rare disease, and I think you have to capitalize on this special designation of rare disease. Once you have it designated as rare disease, all doors open up with regard to drug approval, incentive to pharma, and the pathway through the FDA process, orphan drug program, and getting the drug into the market much, much faster compared to traditional drugs. So capitalizing on the fact that AIH is a rare disease, there's actually no FDA-approved treatment. Everything we do is off-label. These are started in the 50s, even before FDA was there, and then it transitioned after that. And I challenge, Craig, you and your group and AIHA that we are comfortable right now with maintenance to suppress the inflammation or slow down the problem. Why can't we think about cure? I mean, everybody knows the story of Hep C. I mean, it's no longer a problem. Companies are not even looking for new molecules because they say what we have is good enough to take care of the problem. So Hep C has changed overnight and how it is perceived. So why can't we make autoimmune hepatitis in the same way? Why should we settle down for chronic suppression? Why can't we ask, hey, is there a cure? So that I leave you with those questions and suggestions, and I'm happy to walk along with you. And I can't tell you how unique this meeting is. It's using social media, using motivated patients with enthusiasm, and a young investigator who wants to make a mark in the academia. So this aligned very well for us, for you, and hopefully for the disease and other patients in other states. We hope to identify gaps in care and raise awareness. And yeah, nothing ends with talking about the newest addition to our family. This is Hunter Vuppulanchi. I'm told. He's a Yorkie. So 4 months. Thank you.